to the last session for the day, the much awaited keynote talk by Dr. Ajay Vora. I would like to welcome Dr. Ajay Vora to this session, and I would also like to welcome Dr. Hari Menon as the chairperson. Dr. Hari Menon is presently the consultant at Sidecare Cancer Hospital. Previously, he has been the professor and head of hemato-oncology at Tata Memorial Hospital. Welcome, sir. If you could kindly introduce our esteemed speaker for the keynote speak.
Thank you, Vasudha, and it's a pleasure to be here on this fora. It's indeed a great privilege to introduce Dr. Ajay Vora, whom I have interacted with on several occasions when he visited Tata Memorial when I was faculty there. And we have interacted and have listened to him on numerous occasions. And it's always a pleasure to hear him, the lucidity with which he talks and the simplicity which he brings forth the guidelines and the rationale for treating acute lymphatic leukemia the way that we do today. So just to have a brief on Dr. Vora, he is a consultant pediatric hematologist at the specialty lead for hematology and oncology at the Great Ormond Street Hospital. He's also the chief investigator of UK international clinical trials and in childhood leukemia, stem cell transplantation, and CAR T-cell therapy. And he was the previous chair of the UK Childhood Leukemia Group and the IBFM-ALL committee. And we all know how much he has been on the research front, and he has been author to more than 180 peer-reviewed journal articles, which is something incredible. And we all look forward to hear Dr. Ajay Vora's keynote address today, and he'll be talking about the UKALL protocol, 5 decades, and the lessons learned and the future direction. Dr. Ajay Vora.
Thank you, Hari, and thank you, Vasudha, for inviting me to give this talk at the CME event. I must say, having joined 10 minutes ago and listened to the enucleation versus ISC debate, that I've got a very high standard to meet in terms of both the quality of the talks and the evidence that was presented. So I'll try and do my best. Let me just put this on slideshow. Right. Can you see my slides?
Yes.
And can you hear me all right?
Yes.
Yeah. Okay, so my brief is to talk you through the last 50 or so years of the experience of running trials in childhood ALL and latterly adolescents up to age 25 years with ALL and where we are heading. So everyone knows that the outcomes for children with ALL have improved in the last 5 decades. But what people may not be as aware of is that these improvements have been despite there being no new drugs for the treatment of lymphoid malignancies in the same period. And the improvements have been through refinement of the basic treatment template, introduction of risk stratification, and different ways of scheduling drugs. And the credit for discovering the original agents goes to these 4 characters, Farber, Elion, and Hitchings. Everyone will have known about. Subbarao, not many will have heard about, but he was in his laboratory experiments at Ledley Laboratories, the true discoverer of aminopterin and methotrexate, which were then tested with Sidney Farber. His work almost disappeared due to the systemic racism that was prevalent in the US at the time. So these single agents were used as palliation in that period, and many groups were testing them in combination to develop a protocol which could provide a cure. But it was Pinkel at St. Jude's who, in Total Therapy 5, got there first with a publication in the early 70s, which the total therapy template, which we're all familiar with now, starting with induction, consolidation. He introduced cranial radiotherapy after finding that intrathecal chemotherapy was not sufficient with a 30% risk of isolated CNS relapse. And then the term maintenance comes from the fact that when he established this template, he wasn't expecting to cure any patients, but took the risk after 2 years of what we should call continuing oral chemotherapy to stop it. And he published about 40 to 45% event-free survival in the 40-odd patients who were treated with this regimen. And Ching-On Pui, about 10 years ago, published the long-term outcome of these patients in New England Journal of Medicine, and that about 50% event-free survival rate has been sustained in the long term. It was Hans-Jörg Riem in Germany who formed the Berlin-Frankfurt Munster, M stands for Munster rather than Munich, in which he intensified this basic template by adding what he called Protocol 1B, which we increasingly call BFM or augmented BFM consolidation, high-dose methotrexate in addition to cranial radiotherapy. And then he repeated these first 9 to 10 weeks of treatment as what he called Protocol 2, which we call delayed intensification, followed by 2 years of maintenance, and demonstrated an event-free survival of 70%. We in the UK, Judy Chessels, ran a trial between 82 and 86, in which she did a randomized comparison of no intensification versus one given early or late, or 2 intensifications, and confirmed that giving 2 intensifications, although the drugs and the scheduling was different, obtained almost the same exact event-free survival as the BFM schedule. But note that even patients who received no intensification had a near 50% disease-free survival, confirming the results of Pinkel's total therapy 5 protocol. This is important, remember, for where we should be heading in the future. 50% can be cured without intensive therapy. We subsequently tested the role of high-dose methotrexate in cranial radiotherapy and found that high-dose methotrexate did not reduce the risk of CNS relapse or improve event-free survival compared with intrathecal chemotherapy. And although radiotherapy was associated with a lower risk of CNS relapse, it was offset by a trend for higher risk of non-CNS relapse, which meant that the event-free survival was exactly the same in the 2 arms. Hence, from that point onwards, we have not used high-dose methotrexate or cranial radiotherapy in the UK. So this is when I got involved in UK trials, was ALN 97, which started with using the original UK schedules, but later adopted the US schedules. But the core randomized questions were, is dexamethasone better than prednisolone, and thagoanine better than mercaptopurine? And thagoanine did reduce particularly the risk of CNS relapse in boys, but was associated with excess liver toxicity, and hence we have continued to use mercaptopurine. And as everyone will know, dexamethasone had a 8 to 10% better event-free survival, depending on different risk groups, which was primarily due to a reduction in CNS, but also systemic relapses. Then 2003 was the first trial where we tested MRD stratification-based de-escalation or escalation of treatment. So Those we considered to be MRD low risk, which is essentially patients who are MRD negative by a sensitive RT-PCR test, had either standard treatment, which was 2 delayed intensification, or 1 delayed intensification. The high-risk patients were those who were MRD positive, and they either continued on the standard arm that they were originally allocated at the start of treatment, or had the augmented BFM, what we call regimen C. And we found that the outcome for the patients who received only 1 DI was exactly the same as those who received 2 DIs. And we have just done a reanalysis of 10-year follow-up and found that this is sustained. There is possibly a slightly excess relapse risk beyond 3 years in the 1 DI arm, but that's more a trend, and the overall survival is the same. And patients who received the augmented schedule, having been MRD risk, had a better outcome than those who received the standard schedule. And again, at 10-year follow-up, this difference has persisted. So the problem we were left with after UKALL 2003 is we've got these excellent survivals, but now there are more patients who are dying of treatment than of active disease. And it isn't just mortality, it's the serious adverse events. And as you will note, a lot of these are related to asparaginase, including osteonecrosis, which is thought to be steroid related, but there's an interaction with asparaginase, pancreatitis, thrombosis, hypersensitivity, encephalopathy occasionally is asparaginase a contributor. And these serious adverse events affect quality of life, which we measured in 2003, which 100 should be normal. Understandably, at diagnosis is below par, which by the end of induction, life's almost not worth living for some of these families. And this included some of the older patients who completed the questionnaires. And although it recovers at the end of treatment, it's still below what it was at diagnosis. So that shows you the impact of the morbidity that's caused by the treatment we're giving. And therefore, the focus of our most recently concluded trial was primarily to try and reduce toxicity. We don't have the unblinded results of the randomized arms, but what I can tell you is both despite the 50% of patients having received de-escalated treatment and a reduction in the intensity of the treatment backbone, regardless of the randomization, we have seen almost exactly the same event-free survival in this trial compared with the predecessor trial of nearly 85% event-free survival for all comers, 95% for some of the good risk patients. And most gratifyingly, we reduced the intensity of treatment for Down syndrome patients, because as many in 2003 died of treatment-related mortality, particularly infection, as did of relapse. And although we continue to see some infection-related mortality, despite this major de-escalation, we haven't seen an excess of relapses. And so far, with relatively short follow-up, 4-year event-free survival is sitting at about 90%. So since the theme of the day is current concepts, I'll tell you a little bit about our next trial, which has just opened in the UK. We're about to start recruiting patients at GOSH in the next couple of months. And because of the law of diminishing returns of increased stratification, leaving us with smaller and smaller groups in which to ask randomized questions, we've got into bed with our Western European neighbors. At last count, 14 countries, but Spain and Cyprus are likely to join as our France, giving us between 1,400 and 2,000 patients a year in which to do our randomized questions. And the major themes of this trial are going to be adopting a much more refined risk stratification models so that we can capture much lower risk patients with a degree of confidence that allows us to de-escalate their chemotherapy backbone further, and then use targeted agents, immunotherapy, in a way not just to improve the event-free survival of some of the higher risk patients, but also going forward trying to reduce the intensity of the chemotherapy backbone, which is one of, before I stopped working, one of my holy grails, which I would like to see adopted widely. So we know in terms of risk stratification, the standard risk factors are that girls do better than boys. They still do. The height of the white cell count is inversely proportional to outcome. B lineage still do better than T, and age under 10 is better than over 10, with infants who have completely different biology have the worst outcome. The important thing to point out is both white cell count and age are linear rather than categorical. So we adopt these slightly arbitrary threshold of white cell count 50, age 10. Every unit increase in white cell count, whether you call it 1,000 in Indian terms or 0.1 in UK units, is associated with a slightly worse outcome, as is age. Every day higher age is associated with a slightly worse outcome. And so we should really be adopting these as linear rather than categorical variables, and I'll come back to that. In addition, we know cytogenetic risk is an important stratifier, with some of the higher risk cytogenetic abnormalities having not an appalling prognosis, but a relatively poor prognosis, whereas those with ETV6 RUNX1, high hyperdiploidy, have a relatively good outcome. And then finally, the most important determinant of outcomes, MRD, we confirmed in UKALL 2003 that those who were MRD negative had a near 95% event-free survival. And on the other hand, those who were MRD positive at the end of induction had a relatively poor outcome, which, as I said, benefited from having intensified therapy. But what we have looked at subsequently, and Anthony Morman's group in Newcastle has done this, is integrating MRD and cytogenetics. And this is a complicated graph, but essentially what it shows is that the darker the color, the higher the relapse risk. And you'll see that at a given MRD level, let's say 0.01% at the end of induction, the patients who have low risk cytogenetics, ETV6 RUNX1, high hyperdiploidy, have a relatively good outcome compared with those with intermediate risk, darker shade, or high risk, even more dark, and also T-ALL. And therefore, to have a single MRD threshold to determine whether your patient is high risk or low risk is not appropriate. And we therefore have adopted different MRD thresholds at different time points in different cytogenetic risk groups in order to say whether they are low risk or intermediate to high risk. And then, as everyone knows, cytogenetics is low resolution when you're using FISH and G-banding. When you start using high resolution techniques such as SNP arrays, or increasingly now whole genome and RNA sequencing, you see that ALL is highly, highly genetically heterogeneous, and we're going to reach a point where almost every individual patient has their own genetic architecture to which we have to target the treatment. We are going to adopt this copy number abnormality classifier, which again, Anthony Mormon's group has developed using SNP or MLPA kits. And these combinations of abnormalities will determine, in the context of cytogenetics and MRD, whether a patient falls into one of the lower risk or higher risk groups. And so we're going to integrate MRD, as I said, different thresholds for different genetic risk groups, cytogenetics, including FISH, and then the copy number abnormalities to essentially have 4, although it's actually 5, because this very high risk group, there will be 2 subgroups, one who will have a transplant and another who might continue with chemotherapy. And as you can see, the most important part of this is that what this allows us to do is to capture 70% of the relapses in this relatively large group of patients, nearly 40% of patients who have a relatively high risk of relapse, although that might not sound numerically high. Most of the relapses are occurring in this group. So we can target this group for either intensifier treatment or using new agents. And that's what we're going to do. We're going to de-escalate treatment for these 2 low-risk groups by omitting doxorubicin, relatively modest, which we may move on to be more ambitious about. These high-risk groups, remember 70% of the relapses are within this group. We're going to add inotuzumab instead of the first cycle of maintenance. And then we're going to introduce some new agents for ABL class. So this is what this figure is purposely blurred because no one, not even I, who have been involved in writing this scheme and the protocol, can remember the details of this. So we're going to have to rely on a computer algorithm that's going to be part of the randomization database that will tell us where the patient is in the risk groups and the details of their treatment. But just honing in on the B precursor ALL patients, retaining this NCI stratification, then the MRD, and then depending on genetics and MRD, we've got these IR low and very low risk groups who will have de-escalation, and then this IR high, which will have inotuzumab. And then for the high risk group, we will have an allocation to CAR T, and as everyone knows, there are so many different iterations of CAR T. I don't have time to go into at the moment. It's likely to be either Kymria or some of the academic CAR T products that we will be using. We're going to introduce nelarabine for T-ALL patients in this group. And then patients who, despite having the intensified consolidation plus minus nelarabine, who blinatumomab, who is still MRD positive, will go on to have transplant. Finally, there's a randomization to a TDM-based introduction of low-dose thagoanine called TEAM study, which we're not going to run in the UK, but will run in other countries. So there is this small minority of patients, about 3% of patients overall, who, despite not having the Philadelphia abnormality, have a gene expression signature which is almost exactly identical to the Philadelphia positive ALLs. These patients have many of the same characteristics as Philadelphia positive ALLs, with a relatively poor event-free survival. And there is now growing case series data, including our own, that they're sensitive to TKI. So we're going to introduce TKI for these patients, who we will identify by day 15 of their treatment, in addition to the standard chemotherapy backbone, with the hope of reducing particularly the induction failure rate and therefore the need to transplant them, but hopefully also long-term EFS. And then we're going to collaborate with COG to test daratumumab in addition to the standard chemotherapy backbone in a randomization. And this is yet to be finalized. And we're waiting on some phase 1 daratumumab data in order to decide whether we're going to go forward with this. Finally, we are in a single arm, non-randomized study, give blinatumomab after 3 drug induction to Down syndrome patients instead of consolidation and interim maintenance therapy. And if they respond as expected, they will go on to have just DIN maintenance. And we have some preliminary data in the UK where we've treated about 10 patients this way, and we can get away with. We're going to have a lot of biological studies which will answer some scientifically relevant questions around biomarkers and the importance of flow cytometry of the spinal fluid in predicting CNS relapse. And I'll stop there to take any questions. Thank you very much.
Thank you, Dr. Ajay Vora. Can you hear me?
Yeah, I can hear you.
Yeah, thank you. Thank you for that, taking us through the series of how the treatment of ALL has evolved and how we have been able to fine-tune the treatment, de-escalate and dose escalate wherever required. So I just wanted your views on, I mean, though we don't encounter a lot of Ph positive ALLs in pediatric population, what is your view on some data that's coming out from China regarding the use of dasatinib in higher doses in pediatric patients with ALL, Ph positive ALL?
So I promise that wasn't a planted question. If you don't mind, I can show you some slides, although it doesn't answer your question. I will try and answer it.
Yes.
So our current trial is this. We're trying to de-escalate treatment by adopting a less intensive, more like our regimen C, or what COG call the augmented BFM schedule, instead of this very intensive high-risk BFM based schedule, which has a 10% TRM associated with high-risk blocks, and this has a less than 5% TRM. And we're hoping that very few patients will need allogeneic transplant. So the next trial will incorporate blinatumomab, very similar to Down syndrome. So TKI plus blinatumomab instead of consolidation and interim maintenance chemotherapy. And this will be a randomization. It's likely to be 3-4 years before this happens. So this answers, I suppose, 2 issues. One is, what TKI should we use? There's been much debate about the Chinese study, which had shown that dasatinib is better than imatinib. There are lots of weaknesses of that study, not least as Chinghon Pui's, I think, or someone else's editorial that accompanied that article said. So we're not yet persuaded that dasatinib is the answer. Partly because of practicalities. We can't get hold of dasatinib as an IMP, unlike you guys who can get hold of a generic. We can't in the West. So at the moment, the plan is to stick with imatinib, but if there is further evidence that dasatinib is genuinely better, then we might switch to imatinib. The second is the data that's coming out of MD Anderson, as well as the Italian group that was presented at EHA. The Italian data has been already published in New England Journal, which suggests that much like for APL, you can actually use chemotherapy-free TKI blinatumomab combination and get 80%, 18-month, 2-year event-free survivals, which is remarkable. And these are in elderly patients who are not fit for intensive chemotherapy.
Right.
So I think personally, this is the way forward. This is what we're going to be hopefully doing in 5 years' time, is using immune therapy to replace existing intensive chemotherapy rather than in addition to.
Yeah, thank you. Thank you for that that answer, Ajay Vora. And if there are any questions from the audience, and Vasudha, would you like to take any odd questions from the audience?
There's nothing on the chat box. If there's any questions, please, you can type it in the chat box, or any questions from the other panelists on board.
Yeah, Vasudha, can I ask?
Yes, sir.
Yes. Yes.
Hi, Ajay, Girish here.
Hi, Girish.
Hi.
So Ajay,
You seem to be getting younger
yeah,
with the years.
mustache is gone. That's all. Ajay, you showed very nicely how treatment is being reduced for the good risk, and we continue to do that. Do you envisage a day that actually the maintenance therapy will come down from 2 years?
Okay, so I should have mentioned that. We are in altogether, as have the Americans, decided we're just going to give 2 years to boys. So it'll be 2 years for both boys and girls. Now, can we come down even further? So there's really interesting, tantalizing Japanese data from a very old study they did back in the 70s, where they shortened maintenance and it failed. They had about 30-40% higher relapse risk after giving about 12 months of maintenance. But they've gone back and retrieved the slides, extracted DNA, and did some genetics on it. They found that there were 2 genetic risk groups that actually could get away with shorter maintenance. And what they're going to do in the next trial is to do a randomization of shorter maintenance, so 18 months versus 2 years in those genetic risk groups. And let's see. And certainly TLL, as you know, most TLLs relapse within 2 years of diagnosis. So, maybe 18 months might be enough for them. The second issue is pulses, causes a lot of morbidity. And we're asking a pulses question as well. Well, we've already asked that in UKALL 2011. And we're hoping the answer will be that we don't need to give pulses.
Okay. And if I may ask, what's the current recommendation for intrathecal therapy and cranial prophylaxis? Are we going to keep coming down on the requirement for that kind of a treatment like we have in T lymphoblastic lymphoma?
So, as you know, the BFM, because they use protocol M or high-dose methotrexate, don't give intrathecals in maintenance, except for Ts who get 2 or 3 in maintenance. And we've adopted the same practice in our 2011 high-dose methotrexate arm. And we're waiting on the results of that. Because in altogether, most of the European countries are using high-dose methotrexate, we were persuaded without our UKALL 2011 results being available that we will give high-dose methotrexate. And therefore, most of our patients won't get intrathecals in maintenance. Whether your neurotoxicity, both short and long term, is any better by giving high-dose methotrexate instead of lots of intrathecals is open to question. You must have all seen the St. Jude's results on long-term neurocognitive problems, which suggests that if at all, high-dose methotrexate is probably a worse player than intrathecal.
Right. If I'm allowed another question, we are talking about nelarabine being introduced into the TALL protocols. Now, just wondering why it's taken so long, because it was way back when the paper in 2011 relapsed lymphoblastic and the activity of nelarabine. I'm talking about adult patients where it was being used. Is it because of the increased toxicity that we are a little bit averse to use it? Because it's been now 10 years and we know nelarabine has good activity in TALL. And any reason why it was not incorporated earlier than now?
So you're right, neurotoxicity was a concern, and there was absolutely no data that it was effective outside the relapse refractory setting. And as you know, with the strict licensing and commissioning of such drugs in the West, we couldn't just use it first line. But the COG have done a large study, 04232, which has shown a benefit in particularly reducing CNS relapses. And therefore, in the US, they're using as standard first-line therapy. Now, there are lots of weaknesses of that study. It was highly confounded by various other randomizations, changes to the treatment backbone, radiotherapy, etc. So we're not entirely persuaded that nelarabine is of value for all patients in first-line therapy. So we're targeting the higher risk patients for it.
Right. And the COG has used for TALL bortezomib-based therapy. What's your take on bortezomib in TALLs?
So the successor to 0434, the nelarabine randomization, was a study where they did a bortezomib randomization, adding bortezomib to standard consolidation chemotherapy. They abandoned that after recruiting 800 patients once they got the nelarabine results, because they couldn't, there's no way in which they could put the nelarabine in and continue the bortezomib randomization. But they presented the data at ASH last year, and they didn't find any benefit in TALL. There's a hint of benefit in TLBL, a hint. But they need longer term follow-up to see whether that's true.
Thank you, Professor Vora. There are a couple of questions in the chat box. I'll just
Yes.
So there is a question about a CD
Right.
positive BALL with poor prednisolone response, and they have gone on to give 2 doses of rituximab to achieve a MRD negative remission. So the question is, do we need to continue rituximab in further courses or treat it?
Yeah, so thanks, Silky. So as you know, we don't give rituximab. The adult group did a randomization. It was presented at EHA year before last, ASH last year, and they didn't find, unlike the French, who did find an improvement in event survival with rituximab, the UK trial did not find a benefit of rituximab. So that's why we don't use rituximab. Now, as to the specific question, as you know, we don't even use prednisolone poor response as a stratifier. So I have to be honest and say to you, what you mean by high-risk treatment. If you mean high-risk blocks, I wouldn't give high-risk blocks to my worst enemy. It's as bad as transplanting patients. It's got a 10 to 15% TRM. And forget about the TRM. It causes a huge amount of morbidity. So if that's the question, no, I wouldn't give high-risk block. But if you're asking, should you give regimen C type treatment, augment BFM? Yes, I would. Metabolites being monitored, yes. So the team study that I mentioned is metabolite monitoring based. As I said, UK, we're not going to participate in team, but we have our own monitoring system in place that is based on doing genotype based stratification depending on TPMT, not T15. And I can send you guys the protocol we're going to use for that. I think that answers Chintan. Is that Chintan?
Yeah, that's Chintan. Yeah.
Chintan's question as well, I think. I hope.
So if there are no other questions, I would really like to thank Professor Vora to take out his valuable time on a Sunday morning. Thank you very much, Prof. And thank you, Dr. Hari Menon, for chairing this session. With this, we've come to an end of a really fantastic virtual CME right from 10 o'clock in the morning. We've overshoot by 1 hour, but it was totally worth all the time, I think. Thank you all the faculty members for joining in, and thanks the participants for a really interactive session. Thank you very much. Professor Vora, if you're still there, Dr. Vandana is asking why 6 TG instead of 6 MP. Would you like to take that last question?
I can. So it's based on some very clever science that you need an understanding of the metabolism of mercaptopurine. But in brief, mercaptopurine, as you know, is a substrate for TPMT, which shunts it into less active methyl mercaptopurine metabolites. And therefore, those who have low TPMT have more of the cytotoxic TGNs. Now, the difficulty with monitoring TGN levels is that it's in red cells, and we're kind of using that as a surrogate. Red cells, as you know, depending on transfusion status, recent chemotherapy, younger red cells may have more or less of the TGNs. So if you actually measure the TGN that's been incorporated into the DNA of white cells, that gives you a more accurate measure of how much cytotoxicity you're going to get from a given dose of mercaptopurine. And the difficulty is that no matter how much you push up your mercaptopurine dose, those who have high TPMT levels will keep shunting all that mercaptopurine into the less active methyl mercaptopurine metabolites. So because thiaguanine is not a substrate for TPMT, it produces the cytotoxic thiaguanine metabolites directly. And if you give thiaguanine, you always get very good DNA TGN levels. So the hypothesis is that you combine a lower dose of mercaptopurine with a very low dose of thiaguanine, which will give you good DNA TGN levels. But also, because methyl mercaptopurine metabolites are not completely inactive, they actually suppress de novo purine biosynthesis, which is what the de novo purines are in competition with the TGNs that are coming from mercaptopurine and thiaguanine. And if you reduce the amount of de novo purines, then these mimics, the thiaguanine mimics, more of them will get incorporated. And so that combination might give you better cytotoxicity. It's a complicated thesis.
Is that for everyone, or is that only for the intermediate risk group that you said?
It's to the NOFA study that forms the basis of it, only found that the DNA TGN levels predicted a better outcome in the intermediate risk high patients.
Thank you.
Thank you very much, everyone. I'd also like to thank Rainbow Children's Hospital for arranging this wonderful meeting. Thank you all. Have a good evening. See you next time.
Thanks, Dr. Vasudha. Thanks, everyone. Bye.